Ankle fractures case discussion. A 58-year-old female with poorly controlled diabetes mellitus presents to the emergency department after slipping on a wet floor. She complains of severe pain, swelling, and inability to bear weight on her right ankle. Physical examination reveals significant swelling and tenderness over the medial and lateral malleoli. There is no skin break, but the area appears tense with compromised capillary refill. Radiographs confirm a bimalleolar ankle fracture with moderate displacement. The patient has a history of peripheral neuropathy, and her HbA1c is 9.5%, indicating poorly controlled diabetes. Given her comorbidities, concerns include wound healing, infection risk, and potential for Charcot joint changes. Key considerations: impact of diabetes on fracture healing. Peripheral neuropathy increases risk of delayed presentation and unnoticed trauma. Microvascular disease compromises wound healing and increases infection risk. Immune dysfunction, higher likelihood of post-operative infections. Risk of Charcot arthropathy. In diabetics, fractures and dislocations may lead to Charcot neuroarthropathy if not promptly managed. Management priorities: initial stabilization, immobilization with a splint or external fixator if needed to reduce swelling and maintain alignment. Definitive treatment, surgery, open reduction and internal fixation is preferred to restore joint alignment and stability. Glycemic control, optimize blood glucose levels pre- and post-operatively to reduce infection and enhance healing. Post-operative care, close monitoring of wound healing, early signs of infection, and pressure offloading. Possible Viva questions and answers. Why are ankle fractures more complicated in diabetic patients? Diabetic patients are prone to poor wound healing, infections, and Charcot neuroarthropathy. Peripheral neuropathy also increases the risk of unnoticed trauma and delayed presentation. What is the significance of glycemic control in fracture management? Poor glycemic control, for example HbA1c greater than 7.5%, is associated with a higher risk of infection, impaired bone healing, and poor surgical outcomes. Optimizing blood sugar is critical for recovery. What is Charcot neuroarthropathy, and why is it relevant here? Charcot neuroarthropathy is a progressive joint destruction seen in diabetics due to neuropathy. It can occur following trauma, including fractures, and may mimic infection or osteomyelitis. What imaging modalities are useful in diabetic ankle fractures? Radiographs, first line for assessing fracture type and displacement. MRI or CT, useful if Charcot arthropathy, soft tissue injury, or infection, for example osteomyelitis, is suspected. What is the preferred surgical approach for bimalleolar fractures in diabetics? Open reduction and internal fixation ensures anatomic reduction and stable fixation. In some cases, external fixation may be needed if soft tissue conditions are poor. What are the risks of conservative treatment in diabetics? Higher risk of non-union, malunion, progression to Charcot joint, and late instability. How can post-operative infections be minimized in diabetic patients? Strategies include optimizing glycemic control, using prophylactic antibiotics, ensuring meticulous surgical technique and wound care. What are signs of Charcot arthropathy to monitor post-injury? Increased swelling, warmth, and redness disproportionate to the injury, coupled with progressive joint deformity on imaging. How does peripheral neuropathy affect fracture management? Patients may fail to recognize worsening symptoms like pain or pressure sores, necessitating vigilant follow-up and protective measures such as custom orthotics. When is external fixation preferred over open reduction and internal fixation in diabetic patients? In cases with significant soft tissue compromise or severe swelling, external fixation may serve as a temporary or definitive stabilization method.